screen, and I am used to Teams, so forgive me. Can you see my slides okay? Because I can't see you all.
I can't see them anymore. I could see them just a second ago.
Oh, okay. Let me
There we
stop
go. Oh.
sharing, because if I share it, oh, this is what I want. Oh, you can't see. No, that's the wrong thing. Sorry.
There.
Okay. Let's see. Let me change my view. Okay, here we go. Sorry about that. So I'm going to go over the presentation objectives, and you can read them here. I'm just going to do an overview of dementia, types of dementia, reversible symptoms, typical aging versus dementia, common warning signs of possible cognitive impairment, risk factors, purpose and importance of early and proper diagnosis, where to start with the diagnosis, the FDA approved drug therapies and disease modifying treatments, current research, and information about North Carolina statistics and our initiatives. So most of you, I'm sure, are well versed in what these terms and abbreviations mean, but I just want to set a level playing field so you can read those for yourselves. And we're going to start off with what is mild cognitive impairment. So it's defined as the stage between typical aging and dementia. It's a decline in cognitive ability compared to baseline. Does not cause any substantial interference with daily activities. People can live with MCI for quite some time, continue to work and manage their daily needs and care. And this condition may or may not progress to dementia and may be controllable. So you can see the little infographic at the bottom. Mild cognitive impairment in the pre-dementia stage, like I mentioned, does not interfere with daily living. And then you can see the progression of the different stages of dementia. There's many different ways to stage dementia. I don't think there's a universal way, but this is an example of one way. So what is dementia? Well, every case of Alzheimer's disease is dementia, but not every type of dementia is Alzheimer's disease. Alzheimer's disease is the one we hear about in the media all the time, but it's most likely because it's the most prevalent, and it accounts for 60 to 80% of dementia cases. So what is dementia? It's really an umbrella term for loss of memory and other thinking abilities severe enough to interfere with daily life. I think there's a misconception that it's just related to people's memory, but it's related to all the things listed on the left, and it can affect someone's judgment as well. They might not make great decisions, or they might make decisions that are not safe for themselves. So safety awareness and judgment are often affected. Language, some people would say language salad, not being able to find the word, but really it's more about not being able to follow along in a conversation. So in social cognition, basically your filter is gone and you say whatever comes to mind, and sometimes act in ways that may not be considered socially appropriate. So other types of dementia: vascular, Lewy body, frontotemporal, others, including Huntington's, and then mixed dementia. So we'll talk about those in more detail throughout the presentation. The really important thing to remember is dementia is not a typical part of aging. So the most common type of dementia, like I mentioned before, is Alzheimer's disease, and accounts for 60 to 80% of all cases. And for people living with Down syndrome, 80 to 90% of them, if they live long enough, will develop Alzheimer's disease. So now we're going to look at healthy brain nerve cells, which are on the right side of the screen. And then we're going to look at brain cells with plaques and tangles that are hallmarks of Alzheimer's disease. You can see in the circles these bundles or tangles, and very different from the image on the right-hand side of the screen. So that just kind of gives you an idea of what affects people's brains when they have Alzheimer's disease. This is another view of comparing brain changes. You can see on the right-hand side, the severe Alzheimer's is very shrunken. There's holes where there are not in a healthy brain, which is on the left-hand side. And then how the brains compare. This is just a visual. The larger shadowed image is what a healthy brain looks like, or the size of a healthy brain. And the darker image that's inset is what a brain affected by Alzheimer's disease looks like. It's much smaller, and it doesn't have the same look in terms of being full and plump. So let's talk about vascular dementia. I would say this is probably the second most common type, and it's a result of reduced blood flow and oxygen to the brain, which kills parts of the brain, and often can be a result of stroke or TIAs or small strokes. It is possible to limit further damage to blood vessels in the body, including the brain. So we'll talk about that in a further slide about risk reduction. So here are some other types. Lewy body dementia. Lewy body dementia was actually discovered right around the time Alzheimer's disease was in the early 1900s, but it wasn't considered to be a very common form of dementia. So it really was ignored for a long time. It wasn't until the mid 90s that it was really being looked at again and starting to be diagnosed. So Lewy body dementia, you're going to have hallucinations, sleep disturbances, maybe movement issues like someone living with Parkinson's, cognitive fluctuations. The memory is less impacted, and it's often misdiagnosed. I think it's pretty hard to diagnose dementia in general, because I think we know a lot about the brain, but I think there's a lot more for us to learn about the brain. So frontotemporal disorders, that is when the frontal temporal part of your brain is affected. The behavioral variant is one where people can get aggressive and be somewhat difficult to take care of because they can be so resistant and can get kind of angry. Primary progressive aphasia is also part of FTD, meaning that people may lose their ability to speak or to, speak eloquently. Progressive motor decline. Memory is often preserved, and it often strikes people at younger ages, 45 to 65. And again, this is another type of dementia that's often misdiagnosed. So mixed dementia, we're seeing that more and more, and it's usually a combination of Alzheimer's disease and vascular dementia. And then additional types are normal pressure hydrocephalus, Korsakoff syndrome, Creutzfeldt-Jakob disease, posterior cortical atrophy, chronic traumatic encephalopathy. That's what a lot of the NFL players have been diagnosed with. And then Huntington's disease. So reversible dementia symptoms. Dementia and depression are often misdiagnosed for one another because their symptoms are so similar, but it can be related to dementia-like symptoms from an infection, medication interactions, hormonal disorders, high blood pressure, sleep. We're finding out that sleep is really, really important to keeping a healthy brain. Hearing loss is also often misdiagnosed for dementia. In fact, when someone is experiencing a hearing loss and maybe given a cognitive screen and they can't hear everything that's being asked of them, they may score differently than they would if they had proper hearing apparatus, like a hearing aid. Nutritional deficiencies like B12, dehydration, malnutrition, brain tumors, trauma, substance use or abuse. There is alcohol related dementia and low vision. Sometimes people may not see everything or may not be able to read small print. And so they may not be able to follow through, let's say, with a recipe or something like that. And that might be misunderstood or misconstrued for dementia. So let's talk about typical aging versus dementia. So everybody loses things, right? But you can eventually find them later. But with dementia, you lose things and you're unable to retrace your steps to find them. Typical aging would be missing a monthly payment occasionally. You know, we all do that. With dementia, you're not going to be able to manage your budget or balance a checkbook. I don't know how many people still do that by hand, but that's, or adding a series of numbers together, maybe for a bank deposit would be an example. Typical aging, you might forget what day it is, but you can remember that later. And someone living with dementia will be unable to identify the day, eventually losing track of the season or year, often the date as well. Typical aging, you might get lost in unfamiliar places, but you can find your way. I always think of the Seinfeld episode where they lost the car in the parking garage. Don't know if anybody saw that one, but actually that just happened to me yesterday when I was shopping. I could not find my car, had to hit the alarm button, and then I found it. And I'm sure the people around me were not happy, but couldn't find the car. But with dementia, you're going to be at a point where you get lost coming home from a familiar place. Perhaps you've gone to the same grocery store for 30 years and it's, 5 miles from your home and you can't get home. Typical aging, you might sometimes have trouble finding a word, but remember when I talked about before, which is a phrase we should not say to people living with dementia, remember when. We'll talk a little bit more about that later. With dementia, you're going to have difficulty following or joining a conversation. So common warning signs of possible cognitive impairment. This is not an exhaustive list. But this is some of the most common: forgetting recent events, getting lost in familiar places, struggling to follow a simple set of instructions like a recipe, unable to summarize an article or letter that was just read, trouble managing new finances. Now that's going to be a new behavior. Confusion with entering or following conversations, significant changes in mood or behavior that can't be accounted by something else, hallucinations, delusions, or acting out dreams while sleeping. That last one is most often found in Lewy body. And then visual spatial issues, challenges with depth perception. This happened to my mother before she was diagnosed. She was in several minor fender benders because she was having difficulty knowing how to find her spatial awareness. The one thing to keep in mind is that dementia can strike people as early as their 30s and 40s, often referred to as younger onset, but it's not what I think society calls older person's disease. Okay, so these are the non-modifiable risk factors. Age, and age is the biggest risk factor for developing dementia. So the older you are, the more likely you are to develop a form of dementia. Family history, risk genes, and deterministic genes. So deterministic genes are those genes that directly cause a disease. Risk genes are genes that are hereditary in nature. So doesn't necessarily mean that you are going to develop the diagnosis. Gender, race, ethnicity. We know about social determinants of health and how that those three play into it. And people living with Down syndrome, as I mentioned previously, are I've seen figures from 50% to 90% are likely to develop Alzheimer's disease. So let's talk about some modifiable risk factors. There is good news on the horizon. Less education, hearing loss, which I mentioned before, and these are all from The Lancet, which is a journal. And the two items that are in red text were the ones that they added in 2024 when they published a new list on July 31st. So high LDL cholesterol, depression, TBIs, protecting your brain. That's, how people who are NFL players or who have had repeated traumatic brain injuries, a concussion is considered a traumatic brain injury. And you can imagine how many head injuries someone who is playing football might receive. This is also related to interpersonal violence or domestic violence. People who have been strangled and have lost oxygen to the brain, resulting in a traumatic brain injury, may develop dementia. They're probably not going to seek treatment for a concussion or a hypoxic episode. Physical inactivity, keep your body moving. Diabetes has a very strong connection to inflammation. In fact, overseas in the UK, sometimes dementia is referred to as type 3 diabetes. So, really important to make sure if you do have that diagnosis, you're taking good care of it. Smoking, hypertension or high blood pressure, obesity, excessive alcohol, which is what I had mentioned before about alcohol-related dementia, social isolation. We found that significantly impacts people's cognitive abilities, particularly during the pandemic. We saw a big increase. Air pollution, which, some of these you can account for, and also are, social determinants of health and also related to historically marginalized populations. So the other new one that was added was visual loss. So why is it important to get an early and proper diagnosis? To start treating those symptoms early. And like I said, there are some interventions for MCI or reversible symptoms to improve health outcomes and reduce complications. It also allows the person living with dementia to be involved in planning about his or her future and make decisions while they're still able to, and get their advanced directives in order. Those are like healthcare power of attorney, general power of attorney, which basically you assign someone the responsibility for making decisions for you when you're not able to any longer, and also living will, which you can use to say, yes, I want this treatment, or no, I don't want this treatment when I have a certain type of condition, usually an irreversible condition like dementia. It allows the person living with dementia to take advantage of more resources and also provide caregiver support. And family and friends are better able to support the individual living with dementia and help to advance research by participating in clinical trials. The other thing is the new treatments that are available that I'm going to talk about in a little bit are only indicated for people in early stages of Alzheimer's disease. So, where to start with the diagnosis? Start with your primary care provider. I always tell people to get a full medical workup because, like we talked about, there are conditions that can be reversed that mimic dementia symptoms. Neurological assessment, cognitive screening. The clock design is one that I'm sure many of you have heard of, the mini mental, brain imaging. The amyloid PET scan is now no longer under a once per lifetime limit through Medicare, which is very important as it relates to the new medications that are available in the Medicare annual wellness visit. In talking with physicians, there are about 14 pages of things that they are to cover in the Medicare annual wellness visit, and they only have about 3 minutes to talk about cognition. So, that being said, primary care providers might refer to a specialist, a geriatrician, a neurologist, a geriatric psychiatrist or psychologist, or a neuropsychologist. I'm a little biased. I personally feel like the neuropsychology assessment is really in depth and gives you a lot of good information. It is quite taxing for the person who is being assessed. It's usually about 4 to 5 hours, but it really gives a thorough breakdown of what areas someone may have strengths in or what areas they might need help with. So let's talk about the FDA approved drug therapies. To treat the cognitive symptoms, these have been around for a long time. The Aricept, the Exelon, the Razidine. The Exelon comes in a patch as well. There's Namenda and Numzaric. So there's other medications that are used to treat non-cognitive symptoms like insomnia, depression. Benzodiazepines are used for anxiety, and antipsychotics are often used for people who may have hallucinations. There is definitely a black box warning for antipsychotics for people living with dementia. Geriatricians often say start low and go slow. The first set of medications called cholinesterase inhibitors are a class of drugs that prevent the breakdown of one of the neurotransmitters in the brain. They do this by inhibiting the enzyme, which is responsible for breaking down that neurotransmitter. Glutamate is another neurotransmitter that plays a crucial role in brain function, including learning, memory, and cognition. So here's a list of the new medications that actually treat the cause. So the first one, aducanumab, was taken off the market by the company that manufactured it, Biogen, in 2024, I believe, due to the side effects, which the side effects are pretty significant. Leqembi and Kisunla are the other two that are available. And as I said before, it's really only beneficial for people in the early stages. The medication is an infusion and has to be received at an infusion center. And that is usually where people receive chemotherapy. And so it is a pretty rigorous regimen. Dosing is every other week for about a 3-hour infusion session for 18 months. There is insurance coverage available. Medicare Part B will pay 80% of the cost of the drug. And for people fortunate enough to have a Medigap policy, the 20% is often covered by that insurance. Currently, Medicare Advantage plans are not covering the drugs at this time. So The hope was that in early 2025, these medications would be available in an injectable form that could be taken at home. So persons who meet the prescribing criteria would not have to go to the infusion centers, which can be difficult for them, especially if they live far away. If you imagine you have a 2-hour drive to the infusion center, you're there for 3 hours, then you have to drive back home 2 hours. That's really a whole day. Don't know when those will be available, hopefully soon. So, in order to be a person living with Alzheimer's disease to be prescribed with this medication, they must meet the following criteria: have a diagnosis of MCI or mild Alzheimer's disease dementia, have an amyloid PET scan or cerebrospinal fluid to show that the person does have a diagnosis of Alzheimer's disease, and have a mini mental score of 22 to 30. There is a risk benefit ratio. The efficacy rates for these new medications are 27 to 32% effective. But when you compare that to 0, that is pretty significant for some people. There are definite side effects, possibly death, brain swelling, and brain bleeding. That's why the person who is receiving the therapies has to be able to tolerate having spinal taps done or the amyloid PET scans to make sure that the medication is working. So let's talk a little bit about the latest research. So biomarkers is just a short word for biological markers. Alzheimer's blood tests perform as well as FDA-approved spinal fluid tests as of February 2024. Currently, blood tests for diagnosing Alzheimer's disease are not FDA approved, and therefore most insurances will not cover the cost. So blood tests that accurately and reliably detect Alzheimer's signal a shift to a simpler, more accurate, and earlier detection and diagnosis, potentially superseding current methods that are expensive, invasive, and not always accessible. Especially if you live in a rural area, you might not have access to a PET scan, etc. So, blood tests were determined to be about 80 to 90% accurate in identifying Alzheimer's disease in patients with cognitive symptoms seen in primary care and at specialized memory care clinics. In one research study, primary care physicians were 63% accurate, and specialists were 73% accurate when diagnosing, not using the blood tests. So there are definitely some positives about the blood test. So let's talk a little bit about the Sprint Mind. It's a trial that finds lower risk of MCI and dementia with lower blood pressure. So in adults with increased risk for cardiovascular disease, but without diabetes, treating blood pressure to a target less than 120 over 140 may reduce the risk of MCI. And the combined risk of MCI and dementia, according to preliminary results from the Sprint Mind trial presented at the June 25th Alzheimer's Association International Conference in Chicago, indicated that it was potentially a good way to reduce the risk, like I said, of mild cognitive impairment. So let's talk about dementia prevalence in North Carolina. So these are the latest numbers that are available from the Alzheimer's Association. You can see that over 200,000 people age 65 and over in North Carolina have Alzheimer's disease. and almost 12% of adults over 65 in North Carolina have Alzheimer's disease. And let's talk about the caregivers. You can see the large number of caregivers in our state. And look at that, the total hours of unpaid care in the billions. Look at the total value of unpaid care. Another thing to consider is caregivers who themselves have chronic health conditions. Now, it's not clear if they had a chronic health condition before they became a caregiver or if they developed chronic health conditions as a result of being a caregiver. But you can see it's almost 60%, so over half. Caregivers with depression, almost 50%, and caregivers in poor physical health themselves is close to 20%. So let's talk about the dementia initiatives in North Carolina. So it started with looking at the data about ADRD affecting North Carolinians, the fact that most of North Carolina is rural, meaning limited access to specialized care, as listed below, geriatricians, neurologists, neuropsychologists, and treatment, again, citing those infusion sites, and limited access to supportive services in rural areas, respite, caregiver support groups, and caregiver assistance. So rural dwelling older adults have poorer health outcomes than those in urban areas, as illustrated by some of these reasons listed. Here's a timeline of the Dementia Capable, Dementia Friendly work in North Carolina. So in 2014, through a mandate from the North Carolina General Assembly, Senate Bill 744, a task force was to be created and was charged with developing an actionable strategic plan for the state of North Carolina that would address 16 topic areas as they related to ADRD. In March of 2015, the North Carolina Institute of Medicine, NCIOM, convened a statewide multi-stakeholder task force on ADRD. So the 16 areas that they were charged to review were statewide awareness and education, early detection and diagnosis, care coordination, quality of care, healthcare system capacity, training for healthcare professionals, access to treatment, home and community-based services, long-term care, caregiver assistance, research, brain health, data collection, public safety and safety-related needs of individuals with ADRD, legal protections for people living with dementia and their caregivers, and state policies to assist individuals with ADRD and their families. There were 47 task force and steering committee members. The group was made up of physicians, researchers, gerontologists, service providers, caregivers, staff of executive agencies, and legislators. So presentations were provided by content experts, caregivers, and persons living with dementia. In 2017, North Carolina launched a statewide campaign to foster dementia-friendly community pilots. North Carolina's General Assembly also allocated reoccurring funding for a full-time dementia services coordinator to work on these pilots and to work toward implementation of the first Dementia Capable plan for North Carolina, referred to as Dementia Capable NC. The task force developed the Coalition for Dementia Capable NC, often referred to as the Coalition, and the Dementia Capable NC Strategic Plan for addressing ADRD was first published in 2016 and met quarterly to oversee the progress and implementation of the recommendations contained in the state plan. In 2020, the coalition produced a progress report on the status of many recommendations from the 2016 task force. And then in 2022, the next iteration of the plan was published. And the major difference was the inclusion of a whole new chapter. Chapter 2 was added to the plan, which talked about brain health across the lifespan and risk reduction, which was based on the BOLD grant work. BOLD stands for Building Our Largest Dementia Infrastructure. And the grant was awarded to North Carolina in 2020 by the Centers for Disease Control, CDC. And it wrapped up in 2024. Unfortunately, we were not able to apply for the second round of funding. And we continue the BOLD work today, though, through the coalition. So that's very exciting and very important. So these are our current dementia initiatives: the Dementia Capable NC webpage, which I'll walk you through, Coalition for a Dementia Capable North Carolina, otherwise known as the Coalition, the North Carolina State Health Improvement Plan, or NC SHIP, which has a life expectancy work group that's working on brain health and dementia policy priorities. And I co-chair that with 2 other individuals from across the state. The Dementia Friends Program, which I'll go into more detail about later in the presentation, and then Dementia Friendly Communities and Hospitals Network, otherwise known as the network. A Dementia Friendly Communities and Hospitals toolkit was created by one of our contractors and is now available on the Dementia Capable NC webpage. So the Dementia Capable NC webpage, I've included the URL in the different sections. The brain health section was created as a result of the BOLD grant through CDC and includes a toolkit with various resources like customizable pre-made PowerPoints with speaking notes, infographics, and videos, etc., that can be used for training. The coalition, it's got a description and links to the different reports that I mentioned, the Dementia Friends Program, the Dementia Friendly Communities and Hospitals Network. And then we also have a section of website resources for caregivers and professionals and persons recently diagnosed with dementia, and video resources for caregivers and professionals. So the coalition, like I mentioned before, is a body of various collaborators from across the state. We meet virtually on a quarterly basis, and we oversee the progress and implementation of recommendations contained in the Dementia Capable Plan. There are 38 recommendations. So in order to make this more manageable, the coalition votes or has voted on 2 recommendations that they would like to see moved forward. So the 2 recommendations for 24-25 are recommendation 3.2, which talks about enhancing training for healthcare providers on the benefits and best practices for ADRD detection, diagnosis, and service referrals. And recommendation 2.4, which talks about educating healthcare professionals about the importance of treating comorbidities, addressing injury risks, and attending to behavioral health needs among people at all stages of dementia. Recommendation 2.4 is part of that second chapter that I mentioned that was all focused on brain health and risk reduction. So the NC SHIP Life Expectancy Work Group. So we've got 2 policy priorities. Again, it's a lot about educating individuals, caregivers, and healthcare providers, and including direct care workers and community health workers. In my humble opinion, direct care workers are the backbone of long-term care in this country. And without them, a lot of things would not get done and people would not be taken care of. About cognitive decline risk factors, including screening for potential hearing loss and evidence-based interventions to support brain health. Policy priority number 2 is to encourage effective screening and diagnostic assessment to identify early signs of cognitive decline, risk factors, and dementia to reduce risk, slow decline, and manage symptoms. So we're doing a lot of work in these two areas, and I think that these two policy priorities tie in nicely with the two recommendations of the Dementia Capable plan that we are working toward. So next I'm going to talk about dementia friends versus dementia friendly. This is a nice infographic that my friends in Minnesota created. The Dementia Friends initiative or program is really more at the individual level, and the dementia friendly community initiatives is more about a larger community, like a town or a city or even a neighborhood. So what is Dementia Friends? It's actually a global movement to reduce the stigma associated with dementia and can be a part of a dementia-friendly community. I think that's a nice way to start a program off, or a community for becoming dementia-friendly. So Dementia Friends, like I said, is a global movement which was started by the Alzheimer's Society in the United Kingdom to reduce the stigma associated with dementia and to provide information to persons within a community about dementia. Something to keep in mind is that Dementia Friends information sessions are not trainings, they are information sessions. They're provided to community members across our state by trained, in all other states, by trained Dementia Friends champions who are trained by me as the Dementia Friends lead trainer. And in our state, the Dementia Friends champions are mainly housed at AAAs across the state and should be contacted. The AAA should be contacted to request an information session in the community. So one thing to keep in mind is there's 5 key messages about dementia, and we'll go into that a little bit in more detail, and how dementia affects people and how each of us can make a difference for people living with dementia. But you can see the global reach that this has. We've got some work to do, but it looks like it really is a global movement. And this is just the states in the US that are participating in the Dementia Friends program. You can see North Carolina, we've got a little forget-me-not flower. That's the logo or symbol of the Dementia Friends program. So, and we also have territories that have the Dementia Friends program. So let's talk about the 5 key messages. So dementia is not a natural part of aging. Dementia is caused by diseases of the brain. It's not just about losing your memory. It's possible to live well with dementia, and there is more to the person than the dementia. Meaning that, dementia is just a part of a person's makeup, if you will. So if you're interested in becoming a North Carolina Dementia Friend, attend a Dementia Friends information session in your area. And as I previously stated, Dementia Friends information sessions are provided by trained Dementia Friends champions at your local AAA. So let's talk about the history of Dementia Friendly America. The DFA movement began in September of 2015 after the White House Conference on Aging. And it's based on Minnesota's work, their statewide successful initiative called Act on Alzheimer's. Minnesota's got a lot of great programming for older adults, and this is just an example of that. So in 2015, DFA piloted the program in communities across the US, and it took off from there. Okay. Sorry, my slides weren't moving. So in the US, dementia-friendly communities are supported by US Aging, DFA, and there's information available for different sectors, and as a national network of communities, organizations, and individuals seeking to ensure The communities across the U.S. are equipped to support people living with dementia and their caregivers. Dementia-friendly communities foster the ability of people living with dementia to remain in the community and engage and thrive in day-to-day living. So why dementia-friendly healthcare? Healthcare settings play a vital role in providing supportive environments. Dementia-friendly policies not only improve patient care, but also staff satisfaction. So currently, there is not a dementia-friendly hospital or healthcare system designation through US Aging DFA, nor is there a state dementia-friendly hospital or healthcare system designation. There are a few entities that have an age-friendly hospital or healthcare systems designation that I imagine some of you are probably already familiar with. One of them is the Institute for Healthcare Improvement, and IHI's Age-Friendly Health System designation is an initiative of the John A. Hartford Foundation, the Institute for Healthcare Improvement, and the American Hospital Association and the Catholic Health Association of the U.S. This designation focuses on the 4 M's: what matters, medication, mentation, which includes dementia, depression, and delirium across settings of care, and mobility. There are 2 levels of designation through IHI. They are level 1, which is referred to as participant, where teams have successfully developed plans to implement the 4 M's. And then level 2, which is referred to as committed to care excellence, where teams have 3 months of data of older adults who received 4 M's. So just to go into these into a little bit more detail, what matters is know and align the care with each older adult's specific health outcome goals and care preferences, including but not limited to end-of-life care and across settings of care. Medication. If medication is necessary, use age-friendly medication that does not interfere with what matters to the older adult, mobility, or mentation. Mentation is to prevent, identify, treat, and manage depression, dementia, and delirium. And mobility is to ensure that older adults move safely every day in order to maintain function and do what matters to them. So there's another age-friendly measure through CMS, or the Centers for Medicare and Medicaid Services, which focuses on people age 65 and over. The final CMS rule, or the final CMS designation, went into effect in January of 2025 for hospitals participating in the Hospital Inpatient Quality Reporting Program, which is a payment model. This is a Medicare payment system where hospitals received a predetermined fixed amount for each inpatient stay based on the patient's diagnosis and is categorized into a diagnosis-related group, or a DRG, rather than being paid for each individual service provided during the stay. It essentially pays hospitals a set rate for treating a patient with certain diagnoses, encouraging efficient resource use and cost control. So CMS has 5 measures, or 5 domain areas: elicit patient healthcare goals, responsibly manage medications, implement frailty screening and intervention, including for cognition and mobility, assess social vulnerability, such as social isolation, caregiver stress, and elder abuse, and 5, to designate leaders to ensure the equitable delivery of age-friendly care. Hospitals that choose not to participate in the IQR program, which now includes this mandatory measure, face a significant reduction in their annual Medicare payment. And this is just an infographic of the different sectors of a community that can become dementia friendly or can become dementia friends. So you can see hospitals, you can see businesses and employers, communities of faith, banks, transportation, independent living and community engagement, emergency planning, and first response. So let's talk about North Carolina's Dementia Friendly Communities and Hospitals Network. So this, again, is a body of various collaborators from across the state. We meet quarterly on a virtual platform, and we share best practices with each other regarding their respective dementia-friendly work. There is, like I mentioned before, the Dementia Friendly Communities and Hospitals Toolkit to assist those communities and hospitals interested in becoming more dementia-friendly or becoming dementia-friendly, period. So this is just a link to the toolkit, and it provides practical guidance to develop dementia-friendly policies and has steps for assessing, enhancing your healthcare setting. And I've included QR codes, or a QR code, I'm sorry, for the toolkit that can be scanned. And then another item that I had added to the Dementia Capable NC webpage was a compiled list from various providers across the state of contents to include in busy bags, which isn't my favorite term. I prefer soothing kits. For people living with dementia in hospitals, I think you could probably use these in any healthcare setting or in any setting, but it supports comfort and reduces agitation in people living with dementia, and encourage staff to create and utilize these kits. And I've included the link to it as well. And I've also got information about statewide and national resources. These are some national and statewide resources for yourselves, for caregivers, and they can be shared with your clients that may be living with dementia and their caregivers and families. One that is really often helpful are the companion cards that can be accessed from the Alzheimer's Association. It's got a message. It's the size of a business card, and it just says, my companion is living with a cognitive impairment, so that you can, inform other people without necessarily talking about the person living with dementia right in front of them in a discreet manner. So let's see. The next slide talks about Dementia Alliance of North Carolina. Just going to go back for a second here. And they have got the updated Accepting the Challenge video series. I don't know if any of you are familiar with that, but they are now available on their website for free to caregivers. And it features the work of Teepa Snow and Melanie Bunn, and can be very helpful for caregivers and families. Project Care, I imagine several of you are probably familiar with that. It started out as a HRSA grant in 2021 and was only available in 6 counties in the western part of the state, and now serves all 100 counties. The North Carolina Caregiver Portal provides free online on-demand training for caregivers and families about different diagnoses, including dementia, accessible from a smartphone, tablet, computer, through short videos. And then Project Lifesaver for people living with dementia that may display exit-seeking behaviors, often referred to as wandering. And then these are just my references. And here is my contact information. I'm going to stop sharing. If there are any questions.
I'll keep an eye on the chat box, see if anything comes in. I
Okay.
know there've been a lot of requests for your slides, so if you're willing to share them, I can send that out to the group.
Yeah, what I'll do is I'll PDF them and send them to you, Caitlin,
Okay,
and
perfect.
then you can share them with everybody who
Awesome.
would like a copy.
Let's see. One of the questions is, how do the numbers, percentages of people in North Carolina compare with the national average?
You know, that is a good question, and I do not know the answer right off the top of my head.
Lots of
So I can do a little digging and try to find that out. Most of the data that's available is just specific to Alzheimer's disease. It doesn't necessarily break out the statistics into the different types of dementia that I talked about.
Mhm.
So I assume that the numbers that I would be able to get would only be for Alzheimer's disease, if that's okay.
Yeah.
Someone asked about the number of caregivers in North Carolina caring for patients with dementia. I want to say it's over 300,000. I think it's over 300,000. I would have to go back and look at my slide. I don't know the stats right off, but I want to say it's in the 300,000 mark.
And lots of thank yous. Does anybody have any more questions before we end? All right. I think that's it.
All
Heather,
right. Well,
thank you
thank you
so much.
so much. Thanks for having me. Feel free to reach out if you have any other questions, and I will try to get an answer to that question about the number of people living with Alzheimer's disease in the US as it compares to North Carolina and share that with you, Caitlin.
Awesome. And then I can share that out with the group. All right.
Great.
I see a certificate question. This is always a question. Yes, you will get a certificate of attendance. You'll get it by next Wednesday. All right. Thank you.
Thank you. Have a great day,
You too.
everyone. Take
Bye.
care. Bye bye.